Digital Services for Patients and the Public e-update. Mike has kindly just pressed the record button. The session will be recorded so that we can share with other people who aren't able to join in this particular session today. The session has a particular focus on primary care and the work which we're doing with primary care colleagues, because there's an important area of functionality within the NHS Wales app in development, which we'll need to work with colleagues within the services to be able to make that available for patients. I'd like to welcome you all to this session. For those who've been here before, welcome back. For those who are new to this session, then especially warm welcome today, and please pass the word out to others. Our forward look of e-updates is there for all to see, so to speak, and we really appreciate your interest and input into this session. The whole of the e-update will last for approximately 60 minutes. What we've chosen to do today is to segment our part of presenting and giving an update to about 30 minutes, which will give a good 25-30 minutes for questions. We'll take questions by people putting up their virtual hand, but we'll also look to address questions which are posted in the chat bar along the side. If there are too many questions for us to get to today, what we'll do is we'll provide written answers to those questions, which will then pass out to everybody who's attended this call. So, please be assured that we will get to every question which you raise and provide the best answer that we possibly can. Talked about that, talked about questions. I'll talk a little bit about context, because I think that's important as well before I kind of move on. The first point to make is that this service change is a key strand of our work, and it very much coincides with our plans to launch the NHS Wales app later this year. The work we're engaged in is very much iterative in its approach. We're focused on building a momentum of change. So there's not a linear journey with this. It's very much about building ideas and a willingness for people to be able to contribute because they want to contribute. We don't have a big stick, and neither would we want a big stick. We're very keen to work with people who can see the benefits and are willing to try those out so that we can expand for others. The important thing is we're not alone in this space. We're not starting on a complete fresh space, so to speak. And a lot of people are seeking to bring new ways of working together, and we're seeking to collaborate with them. The agenda today, well, we're going to start off with a couple of really important patient stories and experiences, which illustrate some of the problems in both accessing primary care and particularly GP services, also challenges in terms of how repeat prescriptions are ordered, and also challenges in terms of, I suppose, the accuracy of the health record. We're going to start with Kate Jones, and Kate's going to provide some of her experiences of using My Health Online, which has existed for quite some time, but these are kind of very paramount to what we're trying to do with the NHS Wales app. So there'll be a short video where Kate kind of surmises her experience. Then we'll try and bridge to Leslie Bethel, and her experience of really accessing the appropriate medicines to support eye care, which also provide a view which will then provide, I hope, a kind of a rich example of which my colleague Hannah Pike from the Centre of Digital Public Services will seek to illustrate through the work which we're doing, both some discovery work, understanding the problems in the primary care environment, and then actually what we're trying to do to work with a coalition of willing people to address those problems, which help us towards actual design and pilot towards launch of the NHS Wales app. And then lastly, what we'll do is we'll come together for a panel session, which will be Hannah, myself, and Dr. Aled Davis. Aled's a GP and clinical lead in an urgent primary care centre. And he's also a key member of our practitioner assurance group. So Aled will provide a perspective from a clinician's perspective, and also be able to help us with the work which we're doing. We'll take questions for as long as there are questions and the time that allows. So that's the format for today. Hopefully we'll all get a lot from it. For me, the next step really is to ask Mike to play the first video which we've got, which is Kate Jones and her experience. So over to you, please, Mike.
No sound, Mike.
Yeah, I think there's no sound of that video. I'm sure Mike will play it again. I'm sure we can make that work.
Just bear with me 2 seconds. Sorry, Gary.
3 or 4 years ago.
Is that coming through then?
That
Yes,
did
coming
come
through now.
through.
Yep.
I think that was working, Mike.
I've had some mixed results with MHOL, and I can report that some have been good experiences and some less satisfactory. I registered as soon as I was invited about 3 or 4 years ago and was able to make one appointment on one occasion. And I think that was followed up by a text message reminding me of the appointment. But following that, it wasn't working for 2 or 3 years, and I don't think it works now. In fact, the latest one I tried to do wouldn't move from dates that were well out of date. When I spoke to the receptionist, they said they'd stopped doing the online appointments and moved to Facebook. I had had some bad experiences in the past with Facebook and would like someone to show me what to do, but she said they couldn't help. At some point, I went onto the NHS app during the lockdown, and this directed me to MHOL, but with a different username than the one I'd previously chosen. This link stopped working, and now I can get onto MHOL with my old username, but not with the new one. I've successfully ordered medication online more than once using the system. Most recently, I filled in the free text area to explain why I needed 2 tablets that chemists said I was not entitled to have. To my surprise, these medications were supplied on the basis of my request and the justification that I provided. Looking at my medical record, there was only a repeat of my medication record and some incorrect data about allergies and adverse reactions.
Okay, thank you for that, Mike, and thank you clearly to Kate who provided the video. Do we have Leslie on the call?
I think Leslie's having some difficulty joining this morning.
Is she having some difficulty joining?
Yeah, Matt, I've offered to read it out if that would help.
That would, Joe. Yeah, just for the different perspective. So if you
Yeah,
don't mind
sure.
reading out Leslie's patient experience, that'd be really helpful.
No problem. Excuse me while I just bring it up the screen. So this is based on prescriptions. I recently experienced really painful and irritating eye problems. I knew one should attend an optician rather than GP for this problem because of having checked with sorry. Someone said something, sorry. My optician suggested an emergency appointment. When I attended, he made an emergency appointment at ophthalmology in Singleton Hospital, following a conversation with them. But they wanted me to start using antiviral drops immediately, 3:30 p.m. on a Thursday afternoon. But the optician could not prescribe them, so I was told that as he was unable to prescribe the drops recommended by the hospital, I needed to get to my GP to prescribe them urgently, then attend the hospital in the morning. My GP practice is 17 miles from the optician's. I assumed either the hospital or optician could directly contact the practice, but this was not the case, and I had to drive to the surgery and, following the instructions from the hospital, insist they prescribe the recommended medication that day. We arrived just in time before the surgery and pharmacy closed, had to be driven because of eye problems, and had a difficult conversation explaining the urgent need, but was successful eventually. I think if opticians are the recommended professionals to deal with eye problems, then we need them to be able to prescribe or liaise with GPs in order to issue prescriptions. I was fortunate in having a driver and sympathetic optician and hospital doctor to support, but can't imagine how difficult for those without transport. Just one example of how primary care is wider than just GPs. I'm sure dental patients might experience similar issues around the need for shared records accessed by all primary care professionals.
Thank you, Joe, and thank you to Leslie for being able to provide kind of that illustration. I think it's important, and it has been important, everything we're doing within the programme, because we're very much building on real-time experiences and what we can do to be able to address those in our, hopefully, intelligent design. So what I'll do now is I'll introduce Hannah Pike to come in, for Hannah to be able to actually set out what we've asked CDPS to do, the Centre for Digital Public Services, back in January, to understand the problems in the primary care space, and then what we can try to do about it. So I won't eat any of your sandwiches, Hannah, but over to you. The floor's yours.
Thanks, Matt. Would you like me to share my screen, or Mike, is that something that you want to do? Entirely happy either way. We can start sharing.
You can share your screen, Hannah, that's fine.
Cool. Bear with me a second then. You should be able to see it. In a second, I've got a lot of screens open. And I've lost you guys. Cool. Okay, can you all see my screen yet, or is it just loading?
Just loading. I think we're there. We're there on mine.
Cool. Okay, perfect. So hi everyone, thank you very much for letting me come and talk to you today. My name's Hannah, like Matt said. I'm a delivery manager for a project called the Primary Care Pathfinder Project. I just want to start by apologising for my really husky voice. I've got a bit of hay fever going on, as Matt knows. We've had a lot of sessions this week where I've had to mute myself and cough in the background. So if I do go on mute for a second, that is what I'm doing. I'm just trying to breathe a little bit. So I'm here today to talk to you a little bit about the project overall, the story so far, what we found out, and finally what we're now doing and what's happened since the project's finished. So I'll just move on to the first slide. So the Centre for Digital Public Services, which is an arm's length body of the Welsh Government, carried out 12 weeks of research into what the DSPP programme should consider when developing public-facing digital services aimed at improving primary care. So quite a mouthful there, but what does that actually, why did we do it firstly? So the work was commissioned for two reasons. So firstly, the pandemic drove a real period of turbulence in the digital product space for primary care, as I'm sure you're all aware of. And secondly, the NHS Wales app is currently being developed. And there was an appetite for a broader understanding of the entire primary care landscape. So that's what we did at a very high level. I'm going to flash this screen up, and I realise that that's probably too much to consume during this session now. But broadly speaking, the project focused on GP surgeries and citizens with a range of characteristics. We understand that primary care absolutely does go beyond GP surgeries, as kind of Leslie was saying, and it includes pharmacy, optometry, dentistry. However, because of the size of the project, the scope we had and the budget, we decided to narrow that into GP surgery so we could be really specific and thorough in our research. I'm going to flick on to the next screen, which is the story so far, so the interesting stuff really. So what did we find out? Well, I'll talk a little bit about some of the stats, because again, this might be too much to consume on here. But this is a bit of an insight into what we managed to achieve in those 12 weeks. So some stats that I just want to pull out here. So a real key one for us was ensuring that we spoke to deprived practices as well as those other practices. So we managed to achieve 22% of the people that we spoke to were in a deprived practice. So whether that was a practice manager or a GP, 22% of those people that we interviewed were from deprived areas. We got 2 citizens whose first language was Welsh, and even that, to be honest, was a real struggle for a first language of Welsh. We were quite proud of that in the 12 weeks. And then another one there, just the entire kind of health board landscape we covered as well as part of the practice interviews. So even though it was a 12-week focused discovery, I feel like we did achieve quite a lot in there. So what did we find out then? So to give you a bit of a flavour firstly, just going to run down the bullet points on the slide. So rising demand is outstripping capacity, which is forcing the primary care model to change. This is not something new that the project found, but instead validated everyone's thinking, which is just as important really. There's too much demand in general practice and primary care, again, something we already know. The primary care model aims at a very high level, in case you're not aware, to distribute demand more evenly across a wider range of providers. So not just directly to your GP, signposting to pharmacies, for example, as well. It also emphasises place-based care and support closer to home, and encourages citizens to have a more proactive role in their own healthcare. We found that there's a real mix of arguments on both sides for sharing healthcare records with citizens, that is. So it's currently very patchy across the landscape, but the project identified that it is so fundamental to redistributing demand and helping citizens play a more proactive role in their healthcare. And we actually found that a large amount of practice time was spent redacting those records and sharing them with other professionals such as pharmacies. So sharing those across the landscape is kind of the utmost importance in the project's view. And there's also been a flurry of digital interventions, like I said at the start, that has been driven by the pandemic. We found that these digital interventions have not been consistently successful in addressing the two main issues in primary care, which we feel are access and demand management. We found a lot of examples where systems don't integrate with existing systems. So, you know, we've got EMIS and we've got Vision, kind of fundamental systems, and some of those digital interventions didn't integrate with those. So not off to the best starting foot at all. And what that actually meant is more often than not, practices actually ended up turning off that digital intervention. So a lot of money might have been spent developing it, getting it through the health boards and DHCW, and actually it was turned off by practices because it couldn't integrate with the fundamentals. And following on from that as well, the digital tools that have been procured and developed in isolation. So we found a real lack of evidence that there was tools that had been tested with users and also how they integrate on the ground. So for example, that EMIS and Vision problem as well. We spoke to a few that had gone into practices and actually sat down with clinicians, practice managers, reception staff, and worked through the technology. And in those instances, we did found that they were more successful, the digital interventions, but actually that wasn't seen across the board in the majority of cases. They were very much developed in isolation and not tested with users. And finally, just the final point there, and one we all know again, is that there are a wide variety variations in how GP services can be accessed across primary care. So for example, I'm sure we've all kind of been in a situation where you have to call at 8 AM for a same day appointment, but for your practice that might be 9 AM to 9:15. You could have other access methods such as emailing, using e-consult. You have to call at 12 to get your test results. So there's a whole plethora of different ways that you can interact with your GP. And we found fundamentally this caused a lot of confusion for citizens who actually want to do the right thing, but they don't know what to do. So we often found and spoke to a lot of people actually that said, okay, I tried to email or I tried to use e-consult, but I couldn't get to the end solution that I wanted to. So then I ended up just calling into the practice. And we call that something called failure demand, where people try and do the right thing and actually ultimately that has increased demand due to a failure on our part. So that's a bit of a flavour as to what the project found out. We have produced an external report with this in more detail, which we can share with you after the session. So opportunities. So it was really important for us as a project team that we didn't want to produce concrete recommendations at the end of a 12-week discovery. We do not believe we are experts after 12 weeks. People have worked in this industry for years and still struggle to understand it. So it felt really wrong of us to recommend the concrete recommendations at the end of a report. However, we've suggested opportunity areas for more focused work, so definitely identifying topics where there can be more done. So the high value opportunities on the screen in front of you, so a better understanding of the nature of demand in GP practices. So we felt like even though everyone knew that demand was a problem, there'd been no studies done on where demand came from, what happened to demand, and what the different segmentation types are within demand. So a better understanding of the nature of demand is the first step to then improving and tackling demand. Secondly, testing what outcomes can be achieved by enabling and promoting online access to citizens' summary health records. There's a definite perception in the people that we spoke to that if you flick on that switch and allow citizens access to their health records online, it's going to be a surge in demand. However, that's not actually something that's been tested and proved. That's more of a perception. So there definitely needs to be work done in understanding that more. So that's that point there. The third point, improving consistency in how GP services are accessed. Self-explanatory, that one, all that stuff around calling at 8 AM, emailing, e-consult. There should be a general standardised way that a citizen knows how to contact their GP in certain situations, and kind of stripping out that confusion. And then finally, testing out what methods can be achieved, what outcomes can be achieved with a set of multi-channel access methods that have been designed and tested to work together around the needs of the citizen. So they're the high value opportunities that we've identified. And again, there's more detail in the report if you want to go into why we've suggested those and what that kind of shapes up into. So moving on to what has happened since then. So since the project has finished, we've been to the DSPP board a couple of times, which resulted in a work package being agreed, which we're now halfway through delivering that work package. We identified 3 key areas from the discovery: repeat prescriptions, health records access, and online appointment booking, where we feel that there are tactical opportunities that we can target to help the successful launch of the NHS Wales app. There's a lot in that report around access and demand that are strategic problems, and being really open and transparent and realistic, that is going to be a lot of work and absolutely needs to be done, but that's not a tactical opportunity. So here we were really focusing on what can be done immediately to help the launch of the app. So within each of these key areas, we're running a series of work streams. Each work stream will have 2 workshops. The first will focus on defining the problem, and the second will focus on the approach that may tackle the problems identified. So just to give you a bit of an example, so repeat prescriptions was one of our work streams. We had a problem definition exercise. So what are the tactical problems within repeat prescriptions that we understand today? And in the second workshop, we focused on, okay, so now we know these problems, how can we fix them in time for the launch of the NHS Wales app? So quite an ask, but we did that for all 3. It's worth noting that the workshops have been attended by definitely a mix of people. I hope Matt would agree. We've got DSPP, DHCW, and we've got practice managers, GPs, GPC, Welsh Gov, My Health Online, and also CDPS as experts in the digital space. So there's also, I mean, definitely last but not least, we've also got the patient perspective covered in that group as well, who are really vocal as well, which is great to see. So really important that we get a really well-rounded bunch of views really when we're considering the approaches and the problems. So the ultimate aim after these workshops is we will hand over all of this really rich information to DSPP to enable them to shape the ways to tackle the problems to identify with the highest chance of success. So just passing over all of that really rich information. We are partway through now. So like I say, we've just finished the repeat prescriptions and health records access workshop as of yesterday. And we're moving on to online appointment booking Tuesday and Thursday next week. So definitely halfway through there. But what is really key, just a note before I finish, is that everything we've done and are doing is feeding into the transformation plans for the NHS Wales app. And really the intent is for the launch to be as successful as possible for citizens and practices and primary care, obviously. And also take into consideration the views of experts in their field is so key to this as well. So that really takes us up to where we are today. I hope that's given you a bit of a whistle-stop tour of where we are, how we got here. And I'd just like to thank everyone for letting me come and speak to you again today. I can see some familiar faces, so apologies if you've had this feel about our project before, but it is so important to keep you guys up to date. Again, we've got the external report, which has got more information, which I can send round to Mike and Matt to share with you guys after as well. Thank you very much. I think, Matt, pass back to you or Mike.
Yeah, pass back to me. Thanks, Hannah. That was really helpful. There is a question, actually. I can see Alcon Bud has been waiting patiently. Would you like to come in now and just ask your question to Hannah? Hopefully that's while it's fresh.
Yes, thank you very much. One of the things I've noticed is that I know there's been the the COVID and so on. But one of the things I've noticed, having been involved with the hospital and then with the local practice, that I no longer have a GP as such. And it gets very difficult because letters are written to a person who's no longer there, letters from the hospital to the practice, so on. And the other thing I think I know is that all doctors' practices are little private companies. They are separate, and they can make up their own rules about when you must ring up and so on and so on. And so I'm hoping you can cut the Gordian knot somehow. But I mean, it is quite a knot, I would imagine. Have you got anything you could say about that?
All I would say is that we've definitely felt your own experiences there. So when we were speaking to citizens especially, we heard a lot around people saying, I used to, I've been at my practice for 20 years and I know my GP really well. And all of a sudden I can't get an appointment with that person, or they've moved on. And there was a real emphasis on definitely the vulnerable people that we spoke to, that actually that's really important, because even though you've got your medical records, I have a relationship with that person. And so we've definitely encapsulated that in the report, and our job was to capture that and play it back. So unfortunately, no kind of fix around that for you. I wish I could, but it's definitely kind of part of what we fed back into DSPP. And also on the GPs acting as kind of their own mini companies, absolutely. We found huge variations in the way that they operate across the board, really, whether that's geographical or demographics as well. Just massive differences in the way that they operate. And one of our main recommendations was actually we have to tackle some level of consistency in that. There has to be some guidance standards across the board to help citizens understand where to go, what to do in that situation. So unfortunately, I've got no fixes for you, but it's absolutely captured in the report and something that we fed back to DSPP.
Can I just make a quick remark about that? I worked in a university with professors everywhere, and they all wanted their own way of doing things. And I was a health and safety representative for my trades union, Unite. And honestly, I mean, they would not be advised about anything by anybody. And I reckon you might meet the same thing, because you're dealing with intelligent people who've studied for 7 years, and it's hard to expect them to say how high when you say jump. I'll be quiet now.
Oh, don't worry about being quiet. It's really valuable to have kind of insights. And there is challenge, in Wales and across the whole of the UK in terms of that standardisation, which Hannah's described. Look, we've got a question from Deborah, I think, as well. And then I'll talk a little bit about how we're seeking to build on, as I said, the workshops, which are already in progress, and what we're doing in parallel. So let's go to Deborah next.
It was more to reassure Mr. Bubb, because obviously I work in primary care, I'm a practice manager. So I would say in terms of consistency in the way surgeries work, there are access standards where we're all supposed to answer phones within certain times, give a blended model. We're all being asked to provide access data at the moment to say how many we're doing, this, that and the other, to try and assess the volume of work we're doing, but also the consistency of it. I would say if you want to speak to a specific GP, you just ask the receptionist, I want to speak to Dr. X on, and if that doctor is in, they should pre-book. And in terms of letters, I would say there is a big problem at the moment in the Betsy area where they've changed their system, and we're finding we're getting letters coming back now to Dr. Pooled list, even though the referral has gone from a specific GP. So in terms of continuity, it's not necessarily problems caused at the GP end, but it could be external systems that are affecting how we process work. So we've actually datexed that as an issue at the moment.
Thank you.
Thanks, Deborah. Go on, Hannah wanted to come back in, and then I'll probably step on to the next part. Go on, Hannah.
No, I just wanted to finish off by saying sometimes when we present this, or when you read through the report, it can sound quite negative on the GP and practice side, but absolutely we heard that there was a real drive from GPs and practice managers to want help doing this. So like Deborah says, there's absolutely access standards, but are they fit for purpose in helping drive the right behaviours to help GPs and practice managers get people through the door? So I just wanted to finish off by saying that, because sometimes it can come across as quite negative, which it absolutely isn't.
I think we all accept that, and that's really helpful. And as a part to say, as Hannah's described, but the workshops, we've got a series of workshops next week. We will be kind of understanding the feedback from our colleagues in CDPS, but in parallel, we've also been working on with support from colleagues from the My Health Online team who are on this call and from others to identify the practices who may be willing to join us in looking to pilot some of this functionality with particular cohorts of patients, just to see how it works. We're also working to develop the toolkit and the resources which will enable practices to hopefully seamlessly adopt this new functionality. So there's a lot which is going on at the same time. And of course, what we need to be able to do is to be able to go out to everybody in the practice community to inform them about our plans for how we take this to pilot, and then what's next after that. I think the point that I probably should make before kind of formally introducing Alid or asking Alid to introduce himself is to say that, there is no seismic change. There is no, switch for every single practice in Wales to adopt the same way of working from a particular point in time. And so our approach will be iterative, and it will be working with practices on an individual basis to ensure that they've got everything they need to be able to do this across these three areas of functionality which we've described. But there are, clearly a great number of people with experience in this sphere, and so we'll be looking to engage with them. We're already well connected, but we'll be looking to work with those who are most willing to work with us. Right, so without further ado, and we're going to have a wider panel session. Let me just ask Alid just to introduce himself as opposed to me having introduced him, and then we'll take questions for as long as you'd like to ask them. Over to you, Alid.
Thank you, Matt. Hi, everybody. My name's Alid Davis. I'm a GP based in the Rhondda, so I'm clinical lead for an urgent primary care centre. I've been a GP now for 12 years and worked in a few different roles within primary care. So yeah, as Matt said right at the beginning, I've sat on the practitioner assurance group for the DSPP, and it's been a really exciting project really to be a part of, and to actually see how it's developed and how it's coming together. For the benefit of patients essentially, and the public, but I think also from us as our perspective in terms of primary care, it's how we can standardize things a bit better. We've had this sort of massive surge, as Hannah said there, in digital within healthcare. We've embraced it, but at times it's felt a bit chaotic. We've had lots of different things coming at us from all sorts of different angles, and we're having to get used to it as GPs. Practices are having to get used to it, and then you have people then also having to get used to it. And the messages sometimes get a bit confusing and they get a bit jumbled up. And what I'm seeing with the development of the NHS app really is that sort of bringing together and making it a coherent plan, so that we can start building on that. So it's a spine essentially, isn't it? So that we can then start building services on top, which allows that development of a digital approach to healthcare. So yeah, I mean, we're not going to solve all the problems in the world. We're not going to solve all the access issues, but this helps, and I think hopefully it provides some clarity as to where we're going, isn't it? So yeah, I'm happy to field questions. Whether I'll be able to answer them, we'll soon find out.
Thank you, Alid. That was really helpful. Now, the floor is really yours. So we're happy to take questions in the chat, or if people want to raise their hands, we'll provide the best answer we can. But we've also got a lot of colleagues who are experienced, as I said, in the audience who may want to chip in and help us as we go through. So would anyone like to ask a question of us or post anything?
Can I ask about, and I've just put it in the chat bar, in primary care, I feel that we still have barriers to efficient working, such as with the community nursing team. They've got their system. They seem to be developing new ones like these Malinkos or handheld things they've got. But ultimately, they're on one side of an IT Berlin Wall and we're on the other. And they can't, even when they're now building, access shared drive documents because they're on under community IT and primary care under their IT.
It's a valid question. Just see if anyone wants to come in and answer that. What I'd say, I suppose, from the DSPP program perspective is that our engagement has been with the health boards, with respective digital directors, and trying to explain actually what the NHS Wales app can provide. It's not perfect at the moment. It hasn't been perfect, has it, in terms of the stovepipes and silos that you've described. Look, we can't promise through the app to achieve everything, but I think certainly we're trying to change people's mindsets and to show them where they can align more effectively in the future. There's a couple of questions or a couple of hands up actually. Leslie, did you want to come in then, and then perhaps to Alid?
I think that's a particular challenge for end-of-life care in the community, the silos and the inability for patients or the informal carers to know how to access that bridging work, really. Thanks.
Yeah, no, that's helpful. Go on, Alid, do you want to come in on top of that?
Yeah, I think community nurses, it's everywhere, isn't it? That lack of interoperability of people having their own systems for their own thing, and they don't link up. And I think it was mentioned in the chat actually. I think let's go back there. Alan, I think, mentioned it. It is about how you link these up, but also who's also responsible for the data. So I think within primary care, GPs have a big responsibility in terms of managing and being the IG managers of that data. So there is a lot of responsibility that comes with that. So when you're then sharing information with other organizations and other groups, and it's going to be a culture change, isn't it? It really is, because we have to sort of move forward from that. This is our data, we only hold this. But it's for the benefit of people that we share that, but share it in a safe way. And again, there's no easy answer to that. And I don't think necessarily the NHS Wales app is going to solve that problem, but it will help a little bit, I think.
Thanks, Alid. There's a question from Deborah, which I'll go to next, but I think probably Martin's put his hand up. Martin, is yours a related question?
It's related to the access problems, and basically all I would say is some practices work really, really well and are centers of excellence. Other practices have real difficulty in coping, and the reason is down to staffing and the availability. If previously you had 4 GPs in a practice and it's gone down to 2 GPs, they're trying to do twice the workload, and they're looking at innovative methods, bringing in A and Bs and people to assist, but it's not the same. You can't give the same access to 2 patients if there's only half of you available. But what I would wonder is there a way for this to work in reverse and be able to say the correct configuration for a practice would be a certain number of patients for a certain number of medical professionals, whether that be the doctors A and B structure, if they're actually a practice graph, for an ideal practice, because like it is, otherwise it's never going to change. People are going to struggle.
No, thank you for that. I think we recognise that all practices are working really, really hard, to be able to do their best to be able to meet the needs of their particular patients. The more systematic issues, something which the DSPP, isn't there to necessarily do something about in time, perhaps a secondary effect. But you're calling out that as a need is important, I think. So thank you for making that point. If I go to Deborah had a question in terms of who's been involved in the workshops to date. Now, of course, we couldn't bring representatives from all 400 practices into the workshops, given the pace of work which we've been doing, and also the fact that we've been carrying out these workshops virtually. It would be impossible for Hannah and her colleague Adam to be able to kind of draw opinions forward in a productive way. So we took subject matter expert insight from Dr. Sally Lewis, who heads the Value in Health Centre, and also from Dr. Anne-Marie Cunningham, who's Assistant Medical Director within DHCW, to help us with, defining some of those practices who might be willing to participate with us. It's not a closed shop, so I'm looking towards Hannah, but I think that we could accommodate additional practices. And Deborah, if you were available next week and you wanted to be involved, I'm sure that we could make that happen, so that you could play a part in our discussions about appointment bookings.
Well, I was
because
for the previous ones, but I don't seem to have had any invites to future ones.
The work, I suppose, in a nicer sense, with commission from CDPS finishes at the end of next week. Okay. And so we'll then be thinking about next steps and taking to pilot. But, the people who we've been engaged with, we hope by dint that they've contributed their time and their expertise and have bought into the kind of solutions we're moving towards, but they'd be the kind of practices which we'd like to be working with as we move to pilot, as opposed to, in the nicer sense, having to try to pick up with somebody who is perhaps a bit more distant to us. So there's plenty of opportunity. What we didn't want to do is to have, in nicer sense, the same really small group of stakeholders at every particular workshop, because we recognise that would be probably quite a significant drain on your time. 4 hours for 3 weeks is quite an ask, I think, of anybody. But there's lots of opportunity, I think, to be able to work together going forward. Did you want to say anything more? Sorry, go on, Deborah.
I was just going to say an observation on the pilot, because I was at some of the sessions that was talking about piloting the prescription request element, but we've got a high volume of My Health Online users, and I didn't want to confuse patients by maybe piloting a prescription part, but it not be piloting the appointment part, which would mean those patients would have to go in 2 different directions. So that was just an observation on complications when you pilot.
You're right, and it's a really valid observation, because we thought, having started this, we wanted to carry out as much parallel work as we could. But there's a danger, isn't there, as if we'd kind of, in nicer sense, wrapped up what we were going to do in repeat prescriptions and communicated, and then had to communicate again to talk about what we were going to do with appointment bookings or health records. And so there's a logic to this, but we're getting towards the end, in a nicer sense, of our journey with CDPS at this time. And then what we'll do is we'll put a coherent plan out, which we're developing and assuring through our assurance groups, to then go out to engage with those practices which are identified as perhaps the early pilots for us. I don't know if Hannah wants to say anything more there, or whether Joe wants to say anything.
I'm happy to. Yeah, I know, Deborah, thanks so much for your time in the first set of workshops. And like Matt said, it was really important to us that we made sure that we were kind of conscious of taking too much time from people as well. So we have rotated those expertise in the session, as well as giving like a holistic view of different perspectives. But absolutely get your point around piloting different functionality and segmenting that, and we've captured that as we've gone through. Quite a few people have raised that as well, but I will make another note that you've raised it as well, if that's okay, Deborah, and we'll include that in the output.
Yeah.
There's a question which I think Owen's put in the sidebar, which really refers to actually resource to practices to be able to help them to change and adapt. I don't know if Joe, you want to pick up with that, some of our kind of emergent thinking, some of the work you've been doing with Georgie and the My Health Online team.
Yes, absolutely, and Dunk as well. So using the experience that Dunk's had, Dunk Chevis from Kanos, on the work that was done in England, we wanted to, I can see, no thanks Dunk, to explain some of the user cohort survey that we'd like to develop, to get a range of people involved, but also matching that with practices who actually do have the functionality that's being used in My Health Online. I think it's been really important to see, are there differences, are there similarities in what we're providing, and is it easier for patients to use the app as well. Duncan, I don't know if you wanted to jump in.
Just quickly, really. So I think the potentially the point that was being made about piloting, if we're talking about a sort of a cohort of practices to take part in the private beta, we would be looking ideally for practices that are doing, you know, in terms of this, the M-hole features, really the big three. So the repeat prescriptions, the appointments, and access to medical records to some extent. So if part of the pilot, then it wouldn't be a case of you're just piloting a bit, you'd be piloting the app as a whole. So likely all three of those things. So yeah, it wouldn't be a case of sort of one thing on, one thing off, as far as we're kind of aware at this point.
Thanks, Dunk. Let's go to Aled and then probably come back. I can see Alan's added a question in the sidebar, which I think we can kind of centre on. Go on, over to you, Aled.
Yeah, I was just going to go back on to one of the points that Owen raised there. So just we as practices need more resource to make our internal working better, more efficient. And I think that's a really important point, because we've got some practices that are doing tremendous things on their own, essentially. They're developing services, developing pathways that can improve access, improve the working. And those examples of good practice need to be looked at, developed, and brought on in a wider context. And I know, Owen, that you do a tremendous job there in Aberdeen in terms of developing things, and I totally agree with you. I think, you know, it needs examples of how you do it there, and we need to look at those examples and spread that further.
And that's really helpful. And I think it's fair to say that in the workshops, we talked about, you know, some of those measures and metrics which we'd look to establish to be able to, I suppose, inform the case for change, because, you know, I recognise how busy people are out there, and actually to be able to demonstrate that by carrying out this change will deliver a better, you know, experience and outcome for our patients, but in a manageable way, which we can do without kind of opening a floodgate, so to speak, which we can't control. Now, so I saw Alan's added a question in terms of pilot versus private beta. I was keeping things quite general, actually, talking about pilot. Our route is private beta. We want to be able to get to a live release of the NHS Wales app with the primary care, with the functionality described live for the public. Conscious that not everybody, I suppose, is the expert in, should we say, pilot design, so to speak. Any other questions from anybody else? Or is there anything which I've missed? Or any other thoughts from anybody?
Can I ask a question? Sorry, the plumber in. I'm multitasking. I don't know if it covered in the last few minutes. Once you've done the pilot and it's released, I think that from my perspective, I'm quite concerned, because if it's not going to be that patients are migrated automatically to the new app but have to register afresh, then we're going to have patients who are going to have problems. You know, it's just in the nature of them being patients that some will, and it's going to be the demand on the practice team to provide support when we're already stretched to capacity. So what support will there be for practices, for resources to facilitate, you know, the pain of migration?
I suppose what I'd say before I kind of join two other colleagues is that I suppose the migration from My Health Online, in a nice sense, doesn't have to be completed until middle of next year. It is very much focused on our mind and working with the My Health Online team about how that would take place. But our thinking at the moment is that the functionality via the NHS Wales app and My Health Online will coexist for a period of time. And that will give us time to be able to clearly refine what's delivered through the NHS Wales app, and to be able to jointly to develop actually more mature migration plans, and to work through some of those, should we say, those joining issues which you've described. Go on, let's bring Duncan, who can probably add a bit more detail.
No worries. Let me just put my hand back down so that it doesn't become a legacy hand later. I'll caveat it really in that we are still shaping the shape of the private beta. So we need to know whether or not people will need an NHS login to actually get into that, which if they do, it sort of potentially puts people in a simpler situation for moving to the live app when we launch it. Ultimately, the private beta version of the app won't be on the app stores, so people will have to get it through a slightly different means. So we'll be sure to make that really clear for any of the people that sort of volunteer to take part in the private beta. And similarly, at the end of the private beta, which it is then going to be live on the App Store, we'll then be sure to make sure that we've got communications that are really clear in terms of what steps you need to take to essentially move on to the real thing. As for practices and the information that we will likely provide to them, I know there's talk about developing sort of guidance and a toolkit. But obviously we need to know who those practices are, who are going to take part first, and then work with them to figure out exactly what their needs are in terms of the information to help them do the best things for users.
Thanks, Dunk. I can see we've got a hand up from Alan Waldo. Alan?
Yeah, thanks, Matt. So I've got a question. One of the things that I think causes confusion, and it's going to cause increasing confusion in this space, is that our terminology can be problematic. So we're often talking about specific products with brand names rather than the generic function that they enable. So I'm just wondering if you've got plans to go down a kind of white labelling approach where we talk about the functionality that, a bit like Swansea Bay have done. We have a Swansea Bay portal that happens at the moment to be provided by Patient Knows Best, but it's the Ronseal approach. The name you talk about is what it does. I'm just wondering what you're planning to do in that respect.
No, so there's a really good example of bringing up the Swansea Bay patient portal, which colleagues may be aware is one of our Pathfinder projects to be able to, I suppose, demonstrate integration. We're agnostic about vendors, so to speak. The important thing is that connections with the NHS Wales app and how we can use those proven connections and the standards and services which we're going to establish to be able to effectively and seamlessly connect with others over time. Now, colleagues will be aware that actually in the period of November to where we are today, a lot of our focus has been very much building that core functionality within the app itself, that app apparatus in a way. Over time, actually our focus will change and it will be far more about the extensibility of the app. And we have, you could probably appreciate, a lot of join-up work to do across Wales. And that's where a lot of our work is at the moment, engaging with health boards, strategic national programmes, and with others to understand what's out there and what value it could bring, and actually what dependencies would need to be supported to enable it to be connected. And we've got a process for doing that, which we're going out and actually extending that pipeline. We're also looking at what we can do in the immediate term as well, in terms of digital resources, which we can curate and we can provide very seamlessly within the app. But to answer Alan's point, our approach is absolutely kind of vendor agnostic. We recognise that anybody who we work with shouldn't by default restrict access to other vendors in the future. And so we're very much focused on what's going to deliver the benefits to the people of Wales and not involve us being locked into something which we can't get out of. So is that helpful, Alan?
Sorry, I wasn't quick enough on the buttons there. That's a great answer, very reassuring. Thanks very much.
Thank you. We've got 5 minutes left. I don't know if anyone wants to come in or anyone wants to ask any other questions. No? Well, in that spirit, I'll give everyone 5 minutes to have your cup of tea before your next Teams meeting or the like. The next e-update, am I right in saying our next update is going to be on the 15th of July, Mike?
Yeah, it's on the 15th of July, same time, 11 AM, and the registration form to sign up to that is in the chat bar.
Wonderful. So please sign up, if you like what you see. Equally, if we're not doing what you need, then please give us some feedback and we'll try to do better in the future. And please, signpost this opportunity to others, because it's the strength of our coalition which is going to make this a successful delivery. So thank you all. Have a good morning and have a good weekend. Take care.
Thank you. Goodbye.
Thank you.